Dr. Debasis Das Adhikari to speak on emergency department management. Dr. Debasis is Associate Professor and Physician in charge of Pediatric Emergency Medicine, Department of Pediatric, CMC VELLORE. He is instrumental in establishing largest pediatric emergency medicine unit in the country, awarded NABH certification of appreciation, area of excellence. Over to Dr. Debasis.
Thank you, ma'am, for the good words. And I'd like to thank the organizing committee to give me this chance to tell how this pediatric emergency was developed in CMC VELLORE and how we are maintaining the safety of the children through innovative process and through indicators and benchmarking. So if you to look back how it started, so this pediatric emergency medicine, though it started 1970 in USA, probably in CMC VELLORE it was started in 2003, and probably still it's in infancy. And initially it was like very overcrowded place. This is like 2012, if you see our busy resuscitation area room, and being the only emergency department in between Bangalore and Chennai, almost like 500 kilometers. It's remained busy over the years. And even you can see the parents are on chairs and children are getting IV fluids on chairs. Parents are on chairs for 24 hours. There are no bed, no place anywhere. And doctors and nurses are running around. They don't know what to do. And sometimes children are waiting on the corridors and in front of the corridors because there's no place, no bed available. And sometimes the parents are waiting in the waiting areas because casualty is full and they don't want to go anywhere else because they have so much faith on us. This is a short stay area, like sometimes you have to put the mattress because no bed available in this hospital. So it was like chaos. So 2012, we thought that no, that now it has gone to extreme busy place where safety and benchmarking and quality is very important. Otherwise, so treating such a large amount of children everywhere, there is no place for us to breathe also, it's next to impossible. Then we thought, what about this benchmarking and quality performance indicator? Benchmarking is nothing but getting good idea from the best institution and try to implement in your area. And KPIs, they look for the what's the problem and look into, do a good analysis of it and find out the problem, do some innovative and intervention and see whether it's working. And if it is working, try to maintain the trend. Then, as of now, we have only 4 countries for the pediatric emergency, and in that, we are lucky enough got some training from Canada, Toronto University in Sick Kids Hospital. And after the training, when we came back, and we found that we need certain modification in certain areas, like we need modification in our existing emergency. We need a dedicated triage system to find out among the children who are sick and non-sick. We need some innovative techniques, what we have learned in abroad, to implement in our country. And we need a robust documentation system for the safety of the children. And we need some dedicated fast tracking system for the non-sick children to quickly go out of the emergency. And we should have a regular audit in which the safety of the children will maintain. So if you look at the modifications, this is our old RR area, which is packed. You can see the parents are on chairs and children are getting IV fluids. And then over a time, we managed to get a dedicated place. All children have their areas and resuscitation bed and dedicated nurses and doctor teams. And then if you see our observation area, this is our old observation area. Subsequently, we got a dedicated observations area. We have a dedicated doctor and nurses team to look after them. Then if you see this is our short stay area. And subsequently, we got some mattress for them. And now lucky that they have a bed and dedicated place and dedicated doctors for them to look after. And we even got a minor OT to do the minor surgeries and dressing and for the burn patients, and even sometimes we use for isolation bed also when they have some set of contaminated disease like. And then if you see that 2003 till this year 2019, when 2003 we started only with 2 beds. And now we have 32 beds, and this is now currently the largest pediatric emergency in the country. And so, thank you. Next, we have children everywhere, and we have to maintain the standard. It's not like getting treatment and giving them the death sentence. So we have to have maintained the standard of them and safety. For that, we have robust triage system. So we got all the children, when they come to our emergency department, we make sure that they go through this triage system, and we have over a time developed a guideline who are priority 1, who to be seen immediately, the priority 2 children who should be seen in 30 minutes time, and also priority 3 who are not that sick, but we try to see them over 2 hours time. And this protocol was published and was accepted by the National Forum, and most of the pediatric emergencies, they follow the same guideline. And the innovative techniques, which are very important, because these are the techniques we learned when I was in sick kids in Toronto University. And because you know that the number is increasing. You might be thinking my 1,000-bedded hospital is sufficient today, but after 5 years down the line, even 5,000-bedded hospitals won't be sufficient. So what we thought that this 33 bed will be sufficient. In fact, today I'm thinking, regretting why not it's 60 beds, because still children are waiting outside. And see the number in 2003, when it was 5,000, now it has gone to 30,000. And the procedures, what is to do 10,000, it has gone to 60,000. So over a time. So how many beds you have still won't be sufficient. And because population increasing by, if you see that our department, the number says we are severely overcrowded, because we see around 100 to 140 children per day. So the safety is very, very important. And the why it is so important, because if you have a overcrowded emergency department, the death rate has increased by 5 to 10%. And it's the data from USA, it's not our data. So the overcrowded ED may be a death sentence, because there is always risk of 5 to 10% high risk of mortality. And not only that, if you see the satisfactions, patient satisfactions, if they stay for a long time in ED, the satisfaction also goes down. So what happened, how to sort out this problem? We got all these dedicated counters, like when they go for making a chart or pay some bill, or they go to get the medicines, or they go to the blood investigations areas, they get the first priority, because everywhere we put the notice that this area preference will be given to pediatric emergency children. And then we did some more innovative areas. We found that investigation taking very long time, and sometimes getting diagnosis for a child is very difficult. Sometimes we have to depend on some investigations, and that investigation taking very long time. So we try to reduce the turnover, lab turnover time, and did all this innovation in which quickly we can get the report and we can get a conclusion about the diagnosis and can dispose from the emergency department. And sometimes, like some of the instrument, like mini lab we did, we have a multi-sticks machines. Our PICU supports us with a mini ABG analyzer. And most important thing, we try to develop a software which I have used in sick kids and found to be very effective. But when I tried to bring it in India, it was costing us 40,000 rupees per month. Then we have a dedicated IT department who really helped over 2 years' time, and they developed called PEMS software. This is Pediatric Emergency Management Software. So what does this software does and help us? It's helping nowadays, currently it's helping us triaging the sick patients, monitoring our sick patients, investigations, handing over, discharge summary, transfer, data and logbook, research, quality control, and pending charts, time, and also to do an audit on how many times, how many hours or minutes the patient is waiting. And not only that, the patient's also waiting, and if they are not seen, I get a message in my smartphone how many children, how many minutes they are waiting there. I can even control and see from here, this auditorium, what's happening in my department. So this is some of the screenshot of my software. You can see that how I can see outside how many children are waiting there, how many of them priority 1, 2, 3. Child health 1, how many patients are waiting in casualty. Dr. Anna Joseph, how many children has seen from morning. So everything I can analyze from my smartphone. Here also I can find out how many priority 1, priority 2, priority 3 patients are, and how many patients are not seen. I can see now I have 3 patients, they are in white, they are not seen till yet. So my software gives all the glimpse what's happening, and which can be accessed by any senior consultant in charge of the ED by their smartphone. And now also you can see constantly this dashboard in the ED entrance will be reminding us how many children has to be seen by senior. I can see now like the longest time one child is waiting there 10 minutes, and another child just 20 minutes enter the department. So it's always constantly giving us the feedback what's happening in my department. And you might be seeing very familiar in CMC. Now we have around 40 documents which we need regular basis to run our department and to maintain the safety of our children. So these are each box has one document and data which needs to be, if needed, document regularly. And documentation, why it's important? Because through documentations only we will be knowing what happened to the child. Filled up, otherwise child won't be transferred. These are the resuscitation record, must be filled up following resuscitations. And somebody always watching us. You know who is watching us? Yes. They do that. And at the end, they'll send the report to us. We don't know who is watching us, but they watch us. And also all the arrest. All the arrest, gradely we document, we discuss in the department, then they send the report to the medical superintendent's office, and also the 72 hours return. So following a discharge from emergency department, if the child has come back within 72 hours, we have a great details discussion through the chart, and at the end we say them whether the patient discharge was satisfactory or non-satisfactory. So we do all these audits in our department. Our software also giving us continuous idea, like every month it gives us how many children came back following 72 hours, how many are MLC, how many discharged in medical advice, how many had them cardiac arrest, how many survived following cardiac arrest, how many priority 1, how many priority 2, how many children priority 3, total what's the children for this month, like 1/12/2018 to 31st. You just give a click to the computer, our PEM software give all the quality indicators what's needed for the department. So every month we have this, and it's done automatically without any human involvement. It's done with the software. And and we have, following that, we have this in-house and national recognitions. In-house, we got the best area of excellence in CMC by NABH team, and in the country, we got Center of Excellence. Thank you. We have done it, and we can do it together. Thank you.